Хочу поздравить
so far. And Dr. Masui will talk about the abdominal and retroperitoneal MR, and I will talk about the cardiac CT later. And cardiac CT has become one of the parts of radiology. So please enjoy my presentation later. So I'm from Japan, Ehime University. This is my home country. I will talk about the cardiac CT cutting edge. So if we use the multi-slice CT, we can get so many images like this, like a thin slice ham. So let's cook it and let's image heart. So this is the menu for my presentation. Coronary CT angiography, clinical use, and plaque characteristics, and the mini history of cardiac CT, and cutting edge like CT FFR and CT perfusion. One case. This is the patient of 77-year-old male having chest operation, and there is no history of old myocardial infarction, but having the habitation of smoking. So he imaged. He was imaged with the multi-slice CT, and his coronary artery was like this. We can see the severe stenosis in the left circumflex artery here, and stenosis here in the short axial image. So the patient was planned to do the coronary CT angiography next week. Two days after the coronary CT angiography, the patient developed severe chest pain and came to our hospital. And he had the occlusion of the left circumflex artery, just the part, it was pointed out the stenosis here. But acute with the emergency angiography, he was stented and opened the left circumflex artery. But 6 months later, we did the exercise and rest, Thallium 201 SPECT imaging. There was the persistent defect, both exercise and rest. That means the old myocardial infarction, no viability at all. So it was too late to open the occluded circumflex artery. So what is the vulnerable plaque? This is the famous paper written by Dr. Motoyama in JAC 2009, and the characteristics of the culprit region in acute coronary syndrome include positive vessel remodeling, PR, and low attenuation plaques, LAP. She examined more than 1,000 patients and the follow-up of 2.5 years. And the patient developed the acute coronary syndrome in 11 patients. And 10 of them are having had the both positive remodeling and low attenuation plaque. So the characteristics of the vulnerable plaque was a positive remodeling plus low attenuation plaque. This is positive remodeling. And there are plaque ruptures and the make the artery occlusion. So the prior patient, we examined. This patient had positive remodeling and low attenuation plaque. So this is obviously the vulnerable plaque. So we should have done the emergency coronary angiogram to open it. So again, positive remodeling and low attenuation plaque is the important characteristics for the vulnerable plaque. So this is the Japanese research of the Japanese Circulation Society, and the coronary CT angiography is constantly increasing among the cardiac imaging tests. So I will talk about the mini history of the cardiac CT. All the CT scans, one scan, hold the blades and return to the original position and then go to the rotation. And but the helical CT, Toshiba had released the slip-ring CT that can continuously rotate. That made it possible to for the helical scan, but it was the single low detector helical CT. And you know the multi-size CT. So I used the single helical CT 21 years ago to image the heart. If we use the single helical CT, the temporal resolution was not good enough to image the heart. I mean, this is the dancing coronary artery of the right coronary artery. But there was some very stable phase without motion artifact. So we could evaluate the coronary artery using this phase. So I sent our image to the circulation in 1999, and had presented the potential of the single helical CT for the coronary CT angiography. And we got the cover of the circulation. So this is the paging of the single helical CT. So you can see the motion. This is ECG non-gated. CT can make image using the half rotation data. So I started the next slice when we go to the 1/10 of the rotation. I started the next slice and then repeated again. And this is the paging of the 500 slices. And I made the, I manually selected the phase and made this for 3D 4D cardiac CT 20 years ago using the single helical CT and without ECG gating. It took me only overnight work to select each phase. So using the single helical CT, I proposed the potential use for the CT to image the heart, coronary CT, coronary artery, morphology, and myocardial perfusion, left ventricular function, and parameters for the end-diastolic volume and systolic volume and the ejection fraction. So I want to present the image quality, development of the image quality. This is the 4 slice, 16 slice, and 64 slice CT of the same patient. So you can recognize the difference of the image quality. So if I want to say, Japan has a very good lunchbox, like this. Which one do you like? And 16 slice CT and 256 CT. So we can recognize the difference very well. So in summary, the latest CT can image like this, full course dinner, plus in addition with dessert such as function, CT perfusion, and FFR CT without additional radiation dose. By the way, this is the dinner of our hospital. Dr. Tenaboy, unfortunately, worker is prohibited with this dinner. So Toshiba released presented the 256 row detector in 2001 in the Radiological Society North America meeting, and I had a chance to use the prototype machine. The prototype machine had the 4 blocks of the 64 slice CT detector. So this can cover the 12.8 millimeter that cover 12 centimeter that covers the whole heart with 1 rotation. So we used this prototype machine. So all of the 256 slices had exactly the same phase of the images, cardiac phase. This is the first patient who was scanned with the 256 detector or CT, prototype CT in Japan. This is the really patient with AF without ECG gating, without. You can see the arrhythmia very quickly. So, along with the development of the CT can do a lot of applications. CT can do all of these applications, not just coronary CT angiographies. CT-FFR and the plaque shear stress, and image fusion of coronary artery to the perfusion or function, and the TAVI, and the cardiac function, strain. CT can assess the strain like MR, and delayed enhancement like delayed MR, gadolinium enhancement, and the cardiac function, and perfusion, and coronary territory mapping. So I will talk about the cutting edge. This is the famous paper of the FAME trial. So CT, FFR guided PCI, a percutaneous coronary intervention, has the better prognosis than the angiography or anatomy guided the percutaneous coronary intervention. So this is a very famous paper. The coronary CT can do the FFR assessment like this. This is the recent paper of the next trial. So I will skip the detail, but the accuracy is improving. And using the on-site CT-FFR, there are some trials of the CT vendors and workstation companies to measure the CT-FFR on-site. So on-site CT-FFR may be available in the near future. This is also the shear stress assessment using the computational fluid dynamics assessment. We can measure the wall shear stress using the anatomy. So these hemodynamic and geometric indices may be helpful to assess the future risk of the plaque rupture. So this is also the very famous paper by the Hakamovich in Circulation 2003. The x-axis is the degree of the stenosis, namely the summed stress score, and the y-axis is the log hazard ratio of the cardiac death. So if the patient had the stenosis more than 10%, the revascularization therapy or stenting is better than the medical treatment. But if the ischemia is smaller than 10%, the medical therapy is better, had the better prognosis. So we need to assess the ischemic severity or area to make strategy of the coronary artery patient. So y-axis is the real FFR, and the y-axis is the coronary flow velocity reserve. That is coronary flow reserve by pressure wire. And there is the discordant area, FFR normal, but coronary flow reserve was worse. And the other discrepancy is the coronary velocity flow or velocity reserve was normal, and FFR is bad. Which do you believe? So both normal has the best prognosis. But even the FFR is normal, when the coronary flow velocity reserve is worse, that is the worse prognosis. So this part, even if the FFR normal, coronary flow reserve was, when coronary flow reserve was worse, the prognosis is bad. But when the coronary flow reserve is good, even if the FFR is bad, the patient prognosis was not so bad. So, using the ATP stress whole heart dynamics CT perfusion, we can measure the myocardial blood flow, such as milliliter per gram per minute. So we scan every 30 beats, continuous 30 beats, targeting on the systole. And the left side is the movie of the 30 beats. From the dynamic data, we can measure the, using the deconvolution method by pixel-based analysis, we can measure the myocardial blood flow, absolute value. So this patient had the stenosis here in the left anterior descending artery, segment 6. The patient had both MR and CT ATP stress images can match the hyperperfusion area in the anterior septal wall here. And after the percutaneous coronary intervention, I mean the stent, the stenosis was opened and the ischemia was gone. And we can measure the absolute value like this. Play-PCI shows the lower LAD myocardial blood flow, and it was improved to normal. This is another patient having the typical ischemia in the inferior, posterior, or lateral wall here, but you don't know which coronary artery is responsible. So this is the dynamic perfusion of the CT. You can clearly see the inferior hyperperfusion area and slightly hyperperfusion in the anterior wall. So this patient had stenosis here, not the left circumflex artery. This patient had the stenosis in here, in the peripheral side, 4AV or 4 posterolateral branch here, but it has the wide responsible area. This is a culprit lesion, and we can measure the absolute value of the, this is the coronary territory mapping. The LCX is small, and the 4AV area is large. And if you use the standard territory mapping, the LCX may be the borderline of the ischemia, but in this patient, the LCX small and the absolute value was normal. So this part is very ischemic. So this is another patient having the stenosis, triple vessel disease, but the anterior artery area is hyperperfusion in the left, but after a coronary artery bypass operation, the ischemia is gone. And this patient had the stenosis in the segment 7, left anterior artery, segment 7, and the myocardial blood flow territory area is 27% of the whole myocardium. So these are the absolute value. So if you use the whole LAD territory, such as segment 6, the area is the borderline of, I mean the myocardial blood flow is the borderline. But if you measure the segment 7 area, it is significantly ischemic. And when we use the relative flow reserve, such as ischemic myocardial blood flow divided by the normal area, this is very pretty like the FFR. So the x-axis is real FFR, the y-axis is relative flow reserve by CT. This is very similar to the data of the water PET image. So CT can do this. This is a patient of the myocardial infarction here in the inferior wall, where we can punch out the left ventricle and we can highlight the delay enhancement like this. So among the desirable cardiac CT, we have many requests, so many requests. But of all of these, I want to have the highest spatial resolution. Toshiba is developing the ultra high resolution CT, having the detector of 0.25 millimeters. That is, the spatial resolution is less than 0.15, and currently the spatial resolution is 0.35 millimeters with the when you use the 0.5 millimeter thickness detector. So I want to show the image. That high resolution CT is like this. You can see the anterior wall septal branches so clearly, as well as the stenosis in the LAD territory. You can see the short axis so nicely. So septal branches you can see with the when you use the high resolution CT in the very near future, I hope. And this is the instant stenosis. Again, here you can see the instant plaque so clearly. This is the courtesy of the Professor Katada in Fujita Health University. So the future of cardiac CT is so bright, brilliant. Спасибо большое.